Good evening, respected teachers, senior members, and my dear students. So during the next 30 to 40 minutes, we'll have an interactive session with the postgraduates from different colleges. Actually, I thought there would be 5 teams, but I see only 4 teams. What happened to the 5th one? One team is missing. So welcome dear students. ഇത് ഇല്ലാത്തവരൊന്ന് പറയണേ. ഗോകുലം മെഡിക്കൽ കോളേജ് ഉണ്ടോ? ഓക്കെ, വെൽക്കം. ക്യാൻ യു ജസ്റ്റ് ഇൻട്രൊഡ്യൂസ് യുവർ സെൽഫ്? ഡു യു ഹാവ് എ മൈക്ക്?
Hello, good evening everyone. Myself Dr. Anu Srinivas from Gokulam Medical College, final year resident in anesthesiology.
Yes, sir.
Good evening everyone. My name is Reba Maria Matthews. I'm JR3 from Gokulam Medical College.
Okay, thank you. Travancore Medical College Kollam undo?
Yes, sir. I'm Dr. Fatima from Travancore Medical College, Kollam. My colleague is Dr. Sumit. He'll be arriving soon.
Okay. Then Malabar Institute of Medical Sciences, Kozhikode.
Hello everyone, I am Dr. Fahima, secondary DNB at Aster MIMS Calicut.
Good evening everyone. I'm Dr. Adira Anil from Aster MIMS Calicut, secondary DNB resident.
Okay. MES Medical College, PERINTHALMANNA.
Good afternoon, everyone. I'm Dr. Millie Jacob from MES Medical College, second year PG.
Good evening, everyone. I am Dr. Shafsina Erahi. I am a second year postgraduate from MES Medical College.
And finally, GMC Thrissur. Okay. So be calm, right? Be relaxed. And when you speak in a loud voice, right? Speak with confidence, okay? We know LFT or lung function test or pulmonary function test, they provide quantitative measurement of lung function which can be used for many purposes. For evaluating the respiratory system, to quantify the severity of the pulmonary disease the patient has, and you can also monitor the progress of the disease. And once it is diagnosed, you can have an assessment how the patient respond to the treatment, especially bronchodilator therapy. We can differentiate between obstructive and restrictive lung diseases. It is also useful for screening the early asymptomatic patients. Of course, preoperatively, you can assess the risk. Pre-op as well, you can predict post-op. And also, you can predict the resectability in cases of lung resection surgeries. And of course, you can evaluate disability, and finally, it can be used to give fitness for jobs. So when you go through the different PFTs are assessing starting from your muscle strength, the compliance of your chest wall, going deeper, the status of your pulmonary parenchyma, the status of your airways, the pulmonary circulation, and finally, how the gases diffuse, right? So these are the things which we do under PFT. So with this small introduction, I think we will directly go to the Viva session, right? Are you ready? No, are you ready? Actually, I mentioned about the indication. Can you give the indications in a little systematic manner? I think you are from Kozhikode, right? Kozhikode, okay. Kozhikode, PERINTHALMANNA,
So indications for PFT can be broadly classified into two: medical indication as well as surgical indication.
Right.
Coming to medical indication, we can use PFT to diagnose disease, to classify the disease, and to assess the severity of the disease.
Right.
And also we can evaluate the progression of the disease, the response to the treatment, whether it is we are responding, the patient is responding to the particular treatment we are giving. Then in case of occupational exposure, we can use to assess the disability as well as for the coming to the surgical indication, to assess the lung functions which is needed in case of thoracic surgery, upper abdominal surgery. In case of neuromuscular disease, any chest wall deformity, we are using PFT to quantify the disease. Then for assessing the receptibility of the lung in case of pneumonectomy surgeries.
Of course, you mentioned about the surgical indication, right? Can
Yes,
you
sir.
tell more about which are the groups of patients in whom you are interested to do the PFT, like age, type of surgeries, and so on?
Old age more than 70 years of age, we usually advise PFT. Then in patients who are obese patients,
Right.
obesity is an indication. Then those who are undergoing upper abdominal and thoracic surgeries.
Okay.
Then those who are having neuromuscular diseases, scoliosis.
Okay. It is not a neuromuscular disease, it is a chest deformity.
Chest
Okay,
deformity
right.
also.
Then? Okay, what information do you get by doing this PFT in this? What are you going to do with this PFT for these patients which you mentioned?
With PFT, we are assessing the function of the respiratory system in terms of the respiratory mechanics. With the lung parenchymal function is assessed, then the gas exchange.
Right, that is right. But what additional advantage you get? Suppose you are not doing or doing. So by doing it, these patients which you
who are
mentioned,
undergoing surgery, post-operative complications can be prevented. We can
I think you can predict right?
the post-operative complication, and we can start our interventions pre-operatively to reduce the post-operative complications.
Okay, very good. Okay, next person. Any contraindication for doing PFT?
Contraindications, if there is hemoptysis, active hemoptysis, if the patient is having any active transmissible infections,
Okay.
in case of recent myocardial infarction or unstable angina within 1 month, patient who have undergone recent ophthalmic surgeries, neurosurgeries, thoracic or abdominal surgeries,
Okay.
pneumothorax,
Eye surgeries, right?
ophthalmic
Cataract
surgeries,
Okay, then?
any thoracic or abdominal aneurysms,
Yes.
cerebral aneurysms.
Why is it contraindicated in these cases like aneurysms, cataract surgery and all that?
In PFT, the patient is asked to exhale forcefully. So when there is exertion, it can result.
Okay, there is a chance that intrathoracic pressure can rise, and that can be deleterious in these patients. Okay, good. Next, you are PERINTHALMANNA, right? Okay. What are your concerns and what are the complications you expect?
While doing PFT, the patient, we require active effort from the patient is needed.
Very good.
So
Then you need a cooperative patient.
cooperative patient, patient should be obeyed.
So probably somebody with dementia, you can't do PFT, isn't it? Good.
Patient dependent.
And then?
It is so, and also the technician should be also well experienced to give proper instructions to the patient.
Okay.
And also there is high chance if the patient is not doing it properly, there is high chance for wrong interpretation. And also we can confirm the diagnosis only by taking a proper history, physical examination, chest x-ray, and after that only we can come into a proper diagnosis. And just
you mean to say that with PFT alone you cannot come to a diagnosis? You need to have a combination of history, examination and other evidence. Very good. Regarding complications, do you expect any complication? ഇതങ്ങ് ഓഫ് ചെയ്യാമോ? ശബ്ദം ഉണ്ടാകും. Complications. Would you like to answer complications? Can it aggravate asthma? Right? Okay. Next, Can you just help them? What are the probable complications which can happen?
Okay, so the patients maybe like if undetected some any cause of the cardiac problems or this thing, the patient can develop that thing during the PFT, and if it can precipitate asthma attacks while doing this PFTs, and
Sweating,
okay.
syncopes.
Yeah, some patients are prone to like getting syncope when doing exercise, like exertion induced syncope. Those patients can develop that thing, and
Okay, right. So that means your spirometry room or PFT room should be
equipped
having
with all
the
emergencies,
facilities
handling all
to
emergencies. So
manage. Very good, very good. Now coming to the types of PFT, I think you can add types of PFT. Actually, I just mentioned, just enumerate the types
Spirometry,
of PFT. Okay, good.
uh,
Just enumerate.
bedside
Then?
pulmonary function test,
Bedside function test, right?
DLCO2, diffusion of
Okay, diffusion
lung
diffusion test. Then
static and dynamic.
okay, static lung function
function test and
test, dynamic lung function test,
ABG,
right?
pulse oximetry,
Pulse oximetry. So there are different battery of tests, isn't it? Now, Trivandrum, Gokulam, say something more about bedside test.
So the bedside tests are we like to classify into like tests measuring vital capacities and tests measuring vital capacity and dynamic function and other tests.
Right.
So the tests measuring vital capacities, these mainly the bedside pulmonary tests are like non-invasive. We can done at the bedside and easily get a broad idea of what the patient will be having to assess the risk. So the tests which measuring vital capacity include subrachus breath holding test and subrachus single breath count test, and the test which measures both vital capacity and dynamic function includes Schneider's match blowing test and its modification by Othlen and Green.
Can you
and
say more about Schneider's match blowing test?
okay.
Schneider's match blowing.
Schneider's.
How is it done?
So Schneider's match flowing test is done to measure which measures both vital capacity and dynamic function, which is done in a quiet room with there is no airflow and the chin is rested and supported and the mouth is wide open and a lighted match is kept at the same level of mouth at a distance of 6 inch or 15 centimeter, and the patient is asked to blow out the candle with the open
6
mouth.
6 inch or 15 centimeter, right?
Inches.
Okay.
Open mouth with no pursing of lip. So if the patient is able to blow out the match at 6 inches, so it indicates that the patient's FEV1 is for 60 liter per minute, and the FEV1 is 1.6 times 1. Maximum breathing capacity. And if it is Osler had modified that into like kept it to 3 inch and 9 inch.
Okay.
So if it is
You are going to increase the distance, isn't
Distance.
it? From 6 inch you are going to increase. Okay, right.
so if at 9 inch it is like about 150 liter per minute, and if it is 3
Okay,
inch.
right. Just mention the other test also.
So Schneider's match flowing test, Green and Barowitz cough test, and auscultation of over the trachea like forced expiratory time, and Deboner's whistle and right speak flow meter, and other tests include ABG, respiratory rate, and pulse oximetry.
Okay, so there's a big list of bedside function tests, isn't it? So probably the most important one is the clinical examination, right?
Yes.
You need to have a clear history. You can observe the patient, while patient is standing up from the bed, moving, okay, speaking to you. So these are the things which you assess by observation, and you can have all these tests, okay. Next person, can you say something about this Deboner's whistle?
In Deboner's whistle, there's a hollow tube. At the end of it, you have a mouthpiece. At the other end, there is a whistle. At the side, there's a hole which can be adjusted. So the patient is asked to blow through the tube to blow out a whistle, and the opening of the hole is gradually increased till the whistle is no more heard. That reading is read of the flow meter as peak expiratory flow rate.
Okay. Trishur, cough test. So wherever I worked, the PEs used to write cough test positive. Can you say something about cough test?
For doing the cough test, we have to ask the patient to cough very forcefully. After taking maximum inspiration, then ask the patient to cough forcefully. Then if the cough test is positive, it indicates the respiratory muscle function is good. And when the cough is innervated, that is FVC is less than 20 ml per kg, and FEV1 less than 15 ml per kg, and FPC ratio.
Okay, that simply means your patient will be able to cough adequately in the post-op period. And there is one more advantage. If during the cough test, the patient is having the productive cough with sputum, actually that is also that's a part. So actually this same test give you two observations. One is positive thing, another one is a negative thing. Okay, can you say something about Wright's peak flow meter? What does it do? We will come to that later on. What does it do? Wright's peak flow meter.
We can measure the ask the patient to inspire maximally and maximum forcefully expiration. Then in Wright's spirometer, we can measure the peak expiratory flow rate.
Okay, we will come to that later on. Okay. Now, next person. Tell me what are the precautions you take before doing spirometry. Probably your technician will be instructing the patient. Probably patient is asked to stop certain medications. So there is many just mention the important points.
PFT is a effort dependent test. Proper instruction should be given to the patient prior to doing the test.
Good.
If the patient ask the patient to stop smoking 1 hour prior to the test.
Good.
Stop alcohol 4 hours prior during the test. Stop no heavy meals before the test. Then avoid tight clothes while doing the test. Ask the patient to stop doing any heavy work or exercise.
Heavy work.
30 minutes prior during the test. If the patient is on a bronchodilator, the short-acting bronchodilator agonist should be stopped 4 to 6 hours prior to doing the test. The short-acting muscarinic agonist usually 12 hours, like Expiratory. Then long-acting drugs 24 hours for beta-2 agonist, and long-acting muscarinic drugs like tiotropium 36 hours prior to doing.
Okay, good. Then what about the nose clip? What is a nose clip? Why is it mandatory, isn't it? Because they should go only through the mouth. And how many attempts patient can have? Single, double, triple?
Usually 3 attempts.
Okay.
3 trials are done, and best of the 2 should be within 1. The difference between the best of the 2 values should be 100 to 150 ml.
Okay, you take the best one. Okay, patient can have attempts. Sometimes during the initial attempt, a patient may fail. So you have to discard that, and you can ask the patient to have it and take the best one. Good. How do you validate it? Can you say more on acceptability? 2 things you need to remember, isn't it? One is it should be acceptable, and second thing is should be reproducible, isn't it? Can you say, just reading that slide, can you say some more about acceptability? What does it mean?
For accepting the test, the test should start without any hesitation. The peak flow should be attained within 0.12 seconds.
Good.
There should not be any cough while doing the test.
Good.
No aortic closure or valsalva during the test. No inspiration in between the test.
Good.
Then it should not terminate before 10 seconds. The expiration should be smooth and continuous. No cough while doing the test.
Okay. Then only you can say the test is acceptable. Otherwise, you need to put in the garbage. It is written like that. What about the next point, reproducibility? It's written there, reproducibility.
While doing the 3 trials, the value should not vary much. Should be within 5% of each value.
Yes.
Then we can say that the test is reproducible.
Usually 150 ml, 200 ml. That should be the difference, isn't it? Good. Say something about static lung function test.
The static lung function test will measure the 4 volumes as well as the
I can help you. Okay.
4
There
capacity.
is no need to,
Yeah.
say from memory. You can just look at it and tell them.
It will measure the 4 volumes.
You can tell about volumes. The other person can tell about capacities, right?
The 4 volumes are the tidal volume. It is the amount of volume we will inspire or expire during the normal breathing.
Right.
Then inspiratory reserve volume is the extra amount of air we will inspire after the normal inspiration. Normal inspiration, that is tidal volume, more than the tidal volume. And the expiratory reserve volume is the amount of air that is remain in the lungs after normal
Normal tidal
expiration. And the residual volume is the amount of air remain in the lung after forceful expiration.
Okay.
Moving on to the capacities.
Capacities.
Moving to the capacities, we can measure 4 capacities, which includes inspiratory capacity, functional residual, vital capacity, and total lung capacity. Of which.
Okay, what's the anesthetic significance of FRC? As an anesthetist, what is your concern about FRC? Of course, you know the capacities are some volumes. Okay, that I think all of you know. What's the clinical significance of FRC?
First, we have to assess whether the patient belong to a category having lower FRC. The patients like in pregnancy, in neonates, the functional residual FRC will be reduced. So in those patients, while we are inducing, the adequate pre-oxygenation should be done.
What's the function of FRC?
It's the amount. Sorry, sir.
Can you see what is the function? Yes, it is an oxygen reserve. Right. Okay. So it is an oxygen reserve. So how does it help during your induction?
During pre-oxygenation?
Yes.
The denaturation.
Actually, during the period of apnea, it is the oxygen from this
Apnea,
FRC,
yeah.
right? Around 3 liters, which is actually saving the patient from hypoxia. Okay. Now you can see various capacities. Okay. Can you say something about TLC? Is it an important component when you try to interpret PFT, TLC?
Yes, it is. Because using TLC only we can assess the different diagnosis. Like interstitial lung disease.
Or? More broadly
restrictive disease.
Restrictive versus?
Obstructive diseases.
TLC is an important component because when you are confused, when the FE1, FEVC is not sometimes normal, so it is actually TLC is helping you to differentiate whether it is an obstructive or restrictive. Okay, so we have seen many volumes and capacities, right? How can you measure these 3? RV, FRC, TLC? RV, FRC, TLC. How do you measure? Is it possible to measure it through spirometry?
RV, FRC and TLC cannot be measured from spirometry. To measure these 3, we have to do either body plethysmography or the single breath nitrogen washout method, then helium dilution method. These 3 methods are used to assess TLC, FRC and RV.
So, you can see all others are measured with spirometry, but residual volume, FRC and TLC, you need to have these 3 methods you mentioned.
Yes, sir.
Can you just mention the physical law which is made use during
in
body plethysmography?
Yes, Boyle's law is method used in body plethysmography.
No. Can you say something about dynamic lung function test?
Here the volume is measured as a function of time.
In what way this is different from static? Dynamic?
In dynamic lung function test, we are assessing the airway, the obstruction in the airway.
No, before that?
Like flow as a function of time, we are assessing
it is
the
as a function of
time.
Time, right?
Okay. Okay. Here the on the x-axis the volume flow will be there, and on the y-axis it will be.
Can you just mention the dynamic function test?
Yes, forced vital capacity.
Good.
Then FEV1 first, second. Then the ratio FEV1 by FVC, then MBC or the maximum voluntary ventilation,
Good.
then peak expiratory flow rate.
Okay. Tell more about this graph. Or you can say more about FEV1 and FEVC. You can give it to your partner.
This is a FEV1 by FVC graph. This is the forced vital capacity. That is.
How is it done?
The
FEVC?
patient is asked to inspire deeply and expire forcefully as fast as possible.
Yes.
And we get the FVC. And the expired volume in the first minute is the FEV1.
Yes.
So it should be more than 80% of.
Actually around 83%, right? Okay.
In the first second.
Second?
94% and
Third second?
97% in third second.
Okay. And what is its relevance in your diagnosis?
It is mainly used, the ratio is mainly used to differentiate between obstructive and restrictive disease.
Okay.
In obstructive disease, FEV1 by FVC is reduced.
Yes.
Then FEV1 value is also reduced.
Okay.
Whereas in restrictive disease, FEV1 by FVC ratio is increased or normal.
Okay.
And FVC value is reduced.
Okay.
So then we go to look for TLC to find out whether.
Very good. So FEV1 by FEVC. That actually determines which way your patient should go. Is it obstructive? Is it restrictive? If it is normal, it can be a normal or restrictive. Then you need to
look for TLC.
Look for the TLC. Very good. Next. PEFR.
It's peak expiratory flow.
This is a flow meter, isn't it? It measures what?
Peak expiratory flow rate of the patient.
Okay. How is it done?
The patient is asked to take a deep inspiration and forcefully expire as fast as possible.
But the problem with this peak flow meter is that you cannot prolong your expiration. Because you see, there is a mobile thing, isn't it? By 1 to 2 seconds, it will fix. You have to do like this. So usually about 1 second, that pointer will be fixed, isn't it? Unlike other maneuvers, you cannot prolong. Okay, what's the clinical use of PEFR? It's a bedside test, isn't it? You can do in your PAC. Yes. Okay, then. What's the normal PEFR? Normal PEFR. Liters per minute. Would you like to help her? Would you like to pass?
For females, it's 350 to 500, and males, it is 450 to 700. Usually, normal range 500 liters.
Okay, PEFR is a function of dash, 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 dash. Can you fill up?
It's a measurement of respiratory muscle strength,
Good.
the compliance, the elastic property of the lung tissue,
Good.
patient coordination and motivation as well.
Good. One more. Large airways.
Large airways. Large airway obstruction, early indicator.
Okay, suppose PEFR is low. What is your inference?
If it's
Are you worried?
Yes, sir. If it's less than 200 liters per minute, high risk of post-operative pulmonary complications. The patient would be unable to cough and clear out all the secretions.
Okay. So it is a very useful bedside test. Okay. Next.
This picture indicates the flow volume loop. Here the x-axis, we are measuring the inspiration and expiration volume, and then y-axis volume.
So ABCD is written, isn't it? Can you say what is ABC? What is?
ABC indicates inspiration, and the upper part is CDA indicates the expiratory volume.
Very good. What is CD?
Peak inspiratory flow rate.
Very good.
And the CA is the FEC.
Okay. It's there. Just read it. ABC is inspiration, oval. ACD, triangular expression. ABCD is the muscle dependent part of the loop, right? ABCD. And DA is that means that mid part is effort independent. AC is vital capacity. And CD is peak expiratory flow rate. Very good. What does it mean? What message this picture conveys?
This diagram shows the maximum with the expiratory flow rate. This is the
Maximum expiratory flow rate.
maximum
What is the meaning of MEF 75, MEF 50, MEF 25?
It is the expiratory flow during the PC manner, 25% to 75% part of the PC. This means it is an effort independent flow which occurs during the middle part of the PC manner.
So when you look carefully, you can see that 75% of that vital capacity, MEF 75, then 50, you can see the line is dropping down, isn't it? And you are interested about this FEF 25 to 75, isn't it? And what's the name given for that?
Maximum mid-expiratory flow rate.
Mid-expiratory flow rate, MEFR. It is also known as FEF 75 to 25. And what is the significance?
It is an effort independent.
Okay, there is abnormality in that area. What does it mean?
Smaller.
Very good. Next.
This is the flow volume loop showing
Just comment about that inspiratory loop and expiratory. Then it is easy for diagnosis.
the FE1 is reduced. So the FE1 FEZ ratio will be reduced. So this is showing an obstructive pattern.
Okay. If you look carefully, the inspiratory loop is okay, fine. What happened to the expiratory loop?
It's
Scooped appearance.
appearance.
Actually, when you look carefully, it is not only scooped, but has a dog-leg
Dog
appearance,
lens.
isn't it? So it is a typical one of emphysema.
Emphysema.
Next.
Here, inspiration is normal.
Is it normal flow volume loop?
Allah.
When you compare with a normal one which I showed earlier, what are the differences you see? The breadth, the height
All are,
is drastically different from the normal one, right?
all are increased. Actually,
Can I
If-
pass? Oh, can you help?
FEV1 by F1.
Okay.
In this graph, the FEV1 as well as the FEZ is reduced.
Okay.
So it can be either
What happened to that peak?
Peak
has
is
gone up,
increased.
isn't it? So it has an appearance of
Which
which cap?
Which
So
cap?
typically seen in
interstitial lung disease.
interstitial, usually in restrictive lung disease, it is seen. Because you can see that RVTC gap is also shortened, isn't it? And the PEFR duration flow has gone up also, right? Next for you. We just comment about this graph, which includes normal, obstructive, and restrictive. You can tell me about few examples of obstructive lung conditions and restrictive lung conditions.
The down first.
Okay, the upper one?
Upper one is the
Normal.
normal.
Okay.
Then on the left side is the obstructive pattern of the flow volume loop.
Which has a typical
Coving in the expiratory
scooped
appearance.
The other one was a dog-leg
Dog.
appearance. Okay,
Then the next one is the restrictive.
restrictive. Actually, it has a miniature normal one, isn't it?
Yes.
Miniature one. Can you mention few examples of obstructive lung disease?
COPD, emphysema,
Okay. What about restrictive?
neuromuscular diseases.
You can think about anything from your muscles, the chest wall, okay, lung parenchyma, okay, anywhere, any problem which can restrict, can lead on to restrictive lung disease. ILD, she already mentioned. Next.
In this part, the expiratory part is being straightened. So it may
Expiratory
part is
expiratory or
sorry, inspiratory part is
inspiratory loop is
flattened.
flattened or plateaued, isn't it? Plateaued. But the expiratory loop appears normal. So what could it be?
Extrathoracic obstruction.
What's the mechanism? How does it happen? So there is a lesion outside the thorax. During inspiration, what happens?
During inspiration, atmospheric pressure will be more than the tracheal pressure.
So this is the upper, the extrathoracic area, right? There is a lesion like this. This is the lesion. So during inspiration, what happens? Just moves in. So which phase is going to get affected?
Inspiratory part.
Inspiratory phase. So naturally,
That will be flattened or flattened.
Flattened. So it is extrathoracic. One more adjective is needed. Variable
extrathoracic obstruction.
Okay. So you should have the mechanism clear in mind. During inspiration, it moves in. And examples of extrathoracic variable.
Any tracheal tumors?
Then? Can you help them? Examples.
Single vocal cord palsy.
Pardon?
Single vocal cord palsy.
Okay, vocal cord palsy.
Unilateral palsy. Tracheomalacia.
Okay.
Large thyroid tumor.
Pardon?
Large thyroid tumor.
Large thyroid tumor. Okay, very good. This is also for you, next one. How much time is left behind? 10 minutes?
Large.
What is it? Just comment on this flow volume lobe.
Both inspiratory as well as the expiratory curves are blended.
Flattened.
Flattened.
Light out. Okay.
So large airway.
What will be the reason?
Large airway.
Large airway.
Large
Adjective? Intrathoracic, extrathoracic, variable, fixed.
Fixed upper airway obstruction.
Fixed obstruction, because that is why both inspiratory lobe
As well as
and
the
expiratory
expiratory
lobes
lobes
are affected. So whenever you see something like that, it is a fixed obstruction, isn't it? Because it cannot change its diameter. Okay. Next. Comment on these three and tell me the mechanism, because answer is already there.
First one is variable extrathoracic.
Just to make others understand more. Okay.
These are for various flow volume loops. First one is normal flow volume loops, and the patient the downwards is inspiratory limb and upward is the expiratory limb. And coming to the first one, that is variable extrathoracic obstruction.
Mechanism once again.
Okay. Here like examples like single vocal cord palsy, tracheomalacia, and large tumors over the trachea. And during inspiration, the negative intrathoracic pressure will drive the suck in the tracheal extra.
Okay, that is the reason for plateauing the inspiration.
So during
how is it normal? The expiratory loop is normal
because during the expiratory limb, the positive pressure that will forcefully
okay,
open
very good.
the.
Okay. Now you comment on the variable intrathoracic obstruction. Second one.
Okay, variable intrathoracic obstruction. During inspiration, this is intrathoracic. So during inspiration, there is this obstruction has a hole. So negative intrathoracic pressure will hold away the obstruction. So inspiration will be smoother, and during expiration, this forcefully closes the obstruction. Add-on effect during thing.
Suppose I showed you earlier the obstruction. It is inside the lungs now.
Okay.
This is the obstruction, right?
Yes.
So during inspiration, what happens?
It is fixed.
It is widened.
Widened.
So inspiratory limb is okay.
Okay.
During expiration, when the lung is contracting, recoiling, this obstruction is also worsened. So that is why the expiratory loop is chopped off. So you should know exactly the mechanism, then it is very easy to predict the flow volume lobes. Okay, examples?
Variable intrathoracic is bronchomalacia and distal tracheomalacia, those things.
Okay.
And tumors.
Okay, we have only 7 minutes more.
And
Thrissur. Don't mention about the novel one, just comment about the last, the down 1, 2, 3. There is a drastic difference between first and second, isn't it? In first, it is written as early airway obstruction. What is exactly happening in that flow volume loop compared with the second one? Okay, good. Good. It is not dog per se, it is scoped out. Okay, concentrate on that first one. Just recap that FEF 75, 50, 25. Yes, actually there is a reduction in that MEFR area, isn't it? So that is, it is early, which you may miss clinically, which can be detected with a flow volume loop. Good. Okay. The last, Kollam. You are Kollam.
Kollam, yes, sir.
Kollam. Okay.
The first loop is normal loop.
Good.
The second one is suggestive of restrictive lung
Good.
pattern.
Good.
The third one is an obstructive lung pattern.
Scoped.
Scooped out appearance.
Oh.
And the fourth one is
Both
fixed-
lost. Both lost. Expiratory loop and inspiratory loop.
fixed
Fixed side.
fixed intrathoracic
Okay.
obstruction.
The lowest one.
The inspiratory loop is
Lost.
variable extrathoracic obstruction.
Other
And
one.
the last one is
No. The upper one is chopped. The last one. Variable intrathoracic.
variable intrathoracic.
So we have only 4 minutes left. Anybody? What is this one? This flow volume loop means? Anybody? Pardon?
Respiratory lung disease.
No. The small one, pink one. It looks like a globe.
Total
Pathognomonic of anybody?
neuromuscular disease. Neuromuscular.
Yes, neuromuscular. It is a restrictive lung disease. What you said is absolutely right, but it's a feature of neuromuscular issue. Can anybody say something about, just for completion's sake, DLCO? Kollam.
Diffusion.
Diffusion capacity of lung to
lungs.
carbon monoxide.
Yeah.
It is one of the pulmonary function tests. So,
As the when the FE1 FEZ ratio is
no, comment about that. What is DLCO? What is the significance? Okay, next one.
It's a test to. It's a
So people are competing. See, the teams are competing to answer. Okay.
It's a test to measure the diffusion capacity of the lungs.
Okay.
And the gas exchange. That is, carbon monoxide is highly bound to hemoglobin. So this measures the alveolar ventilation, alveolar perfusion. As
Okay,
well
good.
as the
What factors affecting this DLCO? Factors affecting.
Surface area of alveolar surface area available for gas exchange, thickness of the membrane,
Perfusion, alveolar perfusion.
Pressure head, right.
pressure gradient.
Area, thickness,
Driving pressure and hemoglobin.
also hemoglobin. Can you mention few situations where it is increased?
Polycythemia, alveolar hemorrhages, left to right shunts, cardiac shunts. Decrease in
Anemia, smoking. Okay, we don't have much time, that is why. What's the difference between TLC and TLCO? Because there is always a confusion between TLC and TLCO. What is TLC? Total lung capacity. What is TLCO?
Transfer factor of lung to carbon monoxide, that is corrected for hemoglobin.
Actually, it is another term for DLC. It is a European one. There is some change in the unit measurement. Okay. Can you mention tests for muscle strength? We have only 2 minutes. Tests for muscle strength with values. Test specific to muscle strength.
Maximum voluntary ventilation, we can measure it. The patient has to.
Okay, that gives you an idea. Ini ethra samayam undu? 2 minutes? Okay. Some maximal inspiratory pressure.
Maximum inspiratory pressure.
Values, you know?
If it is less than -25, then the patient doesn't get adequate effort, cannot take adequate effort.
Okay.
And peak expiratory pressure, if it is less than plus 40, then the patient cannot cough out.
Okay, that means your PI max will always be negative value.
Negative value.
Lowest one, as you said, is 25. Max we can go up to 120. What about PI max? Still higher, isn't it? That's the strength of the expiratory muscles. Broncho provocation test. I think we will stop with that. Broncho provocation test. Now we'll have one more question after broncho provocation. Just when what it is.
It is to assess the broncho hyperresponsibility.
Because all asthmatics, when they are subjected to PFT, may not show an abnormal PFT, isn't it?
Those patients with normal spirogram but having a exercise-induced asthma, we give.
What do you do in broncho provocation test?
We give methacholine, it's a muscarinic.
Okay, you provoke bronchospasms and just assess the PFT after that. So be careful because your patient can have varying degrees of asthma. Okay, very good. Bronchodilator reversibility. Because this is one of the objectives of doing it, isn't it?
Yes. If we have diagnosed an obstructive pattern, after the first FV1 manner, we can initiate a bronchodilator, wait for 20 minutes, and we can repeat the manner. And if there is reversibility in the FV1, 200 ml of reversibility and 12% is there.
So that is the key point. That means there should be a change of more than 200 ml
or
greater
than
12%. Then you can say that it has, this patient has a bronchodilator reversibility. I think time is over, right?
17 seconds.
ഇനിയുണ്ടോ? തീർന്നല്ലോ? Okay. So anyway, thank you, all the teams. I think you performed well. And actually, I didn't get much chance to answer, and I didn't get a chance to throw the questions to the audience also. Thank you, teams. Thank you, audience. And thank you, organizers.